Austin from Louisville to organize the hands-on session, and asked him to make the models with the Hospital for Sick Children. So that is how it started, the first hands-on surgical training using 3D printed models, first time in history. So this is the scene that on your left side, Dr. Glenn Van Astel was making an operation in the first model made for surgical simulation. So I was attending how he was doing. I made a model, and then he said, it is much more difficult than he can do the procedure on the real patient. And I was very disappointed. But however, following that statement, he made a very encouraging statement. What he meant was that if it is for training, it is better to be a little bit more difficult in the models than in the real scene. So I think that there is a really positive thinking, and it is very, very good. And then I was really excited to organize the program. So on the middle is that the first time we made 3 different cardiac models for 60 cardiac surgeons attending. So which means that I made almost 200 models delivered to the meeting. And then this is the scene of the meeting. So you can see that it is a part of the room is a sea of people, 60 people means. So the Glenn and I identified 3 things. So one is that the 3D print models really feasible, and then really can contribute to improving the surgical skills. We didn't have any question about it. However, they arranged the meeting in such a way for 2.5 hours for 60 surgeons for 3 cases. It's not really ideal to do it. So therefore, immediately after this meeting, and Glenn and I plan to host a smaller group meeting dedicated for 3D printing. So that is how we started in SICKIS, January 2016. We organized the first host in SICKIS. It was pretty challenging. However, everybody agreed that it was pretty successful. We are very motivated and then excited. So we decided to continue to do every year. Actually, next was not in the next year, and the same year we did again. And then until last year, we did the 5 host sessions in the Hospital for Sick Children. So 3-4 times hosting this, we find that it will be very helpful if we implement that for the in-house surgical trainee. And then in the last 2 years, we are hosting monthly in-house hosted courses for our own surgical trainee. So from this year early, we find that with the COVID pandemic, we are not able to get together. So that's the time that we think about the online course, and then our monthly courses that combine the online and the person-to-person hosted setting. So, however, our annual course cannot be the person-to-person because that is not allowed to get together that many people. And then the second is that your travel is not possible at all. So that's how we decided to host this course very challengingly online. That is today. Okay. The courses that are divided into, actually 2 times is exactly the same. So November 28 today and tomorrow is the first one for one group, and then we're going to repeat exactly the same one December 5 and 6 for the other group. And then here that the lectures are all done, what is that the proctors will do the demonstration session, and then right away you do your own procedure, Zoom to the proctor, so that the proctors they supervise you. That is how it works. And today, the first day, later in the day, so our previous patient, Mr. Peter Butler, we're gonna have a brief talk how he sees this hosted program in the perspective of a previous patient with congenital heart disease. That is very exciting, really speech we're going to have today in the evening, and then second day in the next session. So for the course, here are the proctors. The head of cardiovascular surgery, Dr. David Barron, and then senior staff cardiac surgeon, Dr. Osami Honjo. Our previously, the head of cardiac surgery, Glenn Van Astel, who did all previous courses with us. And then unfortunately, we lost him to Los Angeles. And then, however, he joined back to this meeting. So these are the organizers. I need to appreciate all these people. And then from the right side, the Carolyn Robertson is my administration assistant. She has been supporting this meeting from the first meeting up to now. Is really passionate in really making this program better. And next is the middle is the Dr. Nabil Hussein. He was our research fellow for 3D printing and host program for 2 years until last June. And he is now in the Yorkshire in UK as the cardiovascular surgical registrar. And he contributes significantly to our program. And then online host was the invention in the beginning. On the next is Dr. Zeynep Ucha. She is the board certified cardiovascular surgeon from Turkey, and she also joined us for a year to be a research fellow for the 3D printing program and then host program. Okay, and then on your left side is that Brandon Peel. Everybody has been communicated closely with Brandon, and then Brandon is the really key person to make everything smoothly happen up to now. I think that it will be very good here today because we are very confident and seeing that how Brandon has organized. But however, the online is online. There might be some glitches, but however, I do not think we're having major glitches today. I really give special thanks to Brandon. I can't thank to Peter and Fabiola Butler more than I can. So Peter himself was the patient having tetralogy Fallot. He got the first surgery in sick kids in 1961 by late Dr. Bill Mustard, and follow-up surgery by Bill Williams. And then he has been supporting the hospital for many, many, many years. During his support, he found that the host we organize has a huge impact on the patient care, and Peter and Fabiola kindly decided to support this program, especially for the cardiovascular surgical trainees. And then he is a great advocate for the program to the world. We really thank you, Peter and Fabiola, for the indispensable and then really great support. And then also I would like to thank the Congenital Heart Academy, Dr. Sasha Agati and Dr. Grace Van Lungen. They really supported this program to disseminate the information to the world to know that what's happening here in SICKIS. And then we plan to organize future meetings in close collaboration with Congenital Heart Academy from the start of designing the program. Thank you again, Sasha and Grace, to give us this great opportunity. And then I need to show this photo. So on the left side is that our traditional 3D printed model. And then on your right side is our new model we start to use from this meeting. So which is made with silicone. Is happening. I'm talking about story. What happened is that last summer, our previous cardiac MRI fellow, whose name is Dr. Wal Lee from Seoul, Korea. He's the professor of the radiology in Seoul National University. He also did the 3D printing as we do here in his institution. And then he find that cost for printing is so high, and then also that the material is not completely perfect. So therefore, he began to use that silicon to to make the simulation model. As soon as I saw them, that I asked him to provide me with the information about how he did. And he said he outsourced that service to this company. The reason why I'm showing this company is that actually we were able to make a huge progress in the last just 2.5 months. And then the models you see, case 1 and case 2, are the very, very intense hard work from this company. So interesting is that Jeo Kong, the CEO of this company, told me that he was doing the 3D printing business. However, he watched the Glenn Van Aster and the YouTube interview about the 3D printing for congenital heart disease and host. And that is the motivation how he added the medical business and his 3D printing business. So, and then he recruited the Yunsun Shin. Is very interesting too. So Yunsun says that she was the silicon specialist for film industry for more than 10 years, probably approaching 20 years, which means that she has the all know-hows how to use the silicon. So when I had the first meeting, I could see that the ability of what this company can do, especially the Yunsun herself. So Yunsun and I agreed, let's go for the best we can do with the 3D printing technology and the molding technology. So how we did it? So we divided all the components of files into multiple components. We divided the whole models into several parts, and then we make the molds, and then with molding, and then we produce such parts of the heart. You can see that there are a number of parts, including coronary arteries. Those should be all manually assembled as shown on the right side. That's the product you have here. On your left is the graphic model, and then right is the final product. And then inside is shown here. So here that in this course, you're going to have a 2 silicon-based mold model and then 1 direct 3D printed model. And then we really want to have a kind of the future better with improving the quality of these models and the sessions as well. So at the end of your host, you're going to have an online survey, and then please participate actively in responding to these questionnaires. That will be crucially important for our future. Okay, that's the rather lengthy introduction. I would like to thank you again that participating in this course and then attending this priming session. So we have the 5 speakers for the session. Myself, we're going to talk about morphological overview of transposition of the great arteries. And Dr. David Barron, we're going to talk about technical skills and on the arterial switch operation. And Dr. Andrea Dragulescu is our senior cardiologist whose major interest is the echocardiographic assessment of various situations of congenital heart disease. She's going to talk about pre, intra, and post-operative echocardiographic assessment for arterial switch operation. And then Nabil Hussein, as I mentioned, he was the research fellow for 3D printing program. He's now back in the UK, Yorkshire, doing the registrar for the cardiovascular program. So he developed the evaluation tool for any kind of training. So one is that he is specifically on arterial switch operation, and then as an attendee, when you do the surgery on the models, at the end, you want to evaluate yourself. You can use that evaluation tool. That's how that Nabil will going to introduce how it can be used. And then Nabil also we're going to have this a little bit more time after his talk, and then the moderate a session, getting know each other more. Okay, so try to really network ourselves. Now, lastly, at the end, Brendan Peel, we're going to really summarize how to properly set your operation table, and then Zoom setting and the communication for the host course. Okay. So let me start my talk, the first talk on the transposition of the great arteries, morphological overview. Let me start with this the slide. This is straightforward, complete transposition of the great arteries, or transposition of the great arteries, or detransposition of the great arteries, transposition, or whatever. So the reason why I list is that we use all different names, but however, which could be the best name for this specific disease? So looking at the literature, it is true that the literature lists unanimously that Mr. Matthew Bailey was the first one who described, not named, described transposition of the great arteries. That was 1806. His description and the drawing is fantastic. This is a drawing in his the monograph. So he labeled as aorta, the pulmonary trunk, an ascending aorta, and describes that the trunk of the pulmonary artery arises from the right ventricle. The ascending aorta arises from the left ventricle. Completely precise. However, he didn't name it. So a couple of years later, Dr. Farrer in the England wrote this paper, the sort of monograph book, which is a pathological research on malformation of the human heart. There, in the bottom of the content, you can see transposition of the aorta and the pulmonary artery. So this is the first use of transposition in this particular category. The reason why I introduced this is that why then we talk about the complete transposition? And now there is a tendency, get rid of complete. It is a little bit confusing. Yes, it is confusing. Why it is the complete transposition? So after the Dr. Farrer introduced the term transposition in 1814, a few years later, German doctor, whose name is Olt, described this pathology as partial transposition. What it means is that in transposition, aorta and pulmonary trunk are transposed. However, in this double aortic right ventricle, by future name, aorta is transposed, but the pulmonary artery is not transposed. That's why he introduced the terminology partial transposition. And then people think that if there is a partial transposition, we need to name what is called transposition differently. That's where the complete transposition is from. And in now, nobody uses a partial transposition, and then actually the adjective complete is not needed anymore. So what about detransposition? So detransposition is the most commonly used in North America. And then here, D refers to the right ventricle on the right and the aorta on the right. Okay, that's fine. So that's how that the L transposition was born too. So atrioventricular discordant connection and ventricular arterial discordant connection. You have double discordance. The right ventricle is on the left and the aorta is usually on the left. That is how it is called L transposition. Already this D and L has some issues because that not all D transposition, we're gonna have aorta on the right. Not all cases with L transposition will not have the aorta on the left. The more serious problem is this. What if your transposition occurs in patients with sinus inversus? And would it call L transposition or D transposition? It's not defined. Okay? So mostly the accurate using this term will be detransposition in sinus inversus having aorta on the left side. Probably that is the proper explanation. So there is some limitation in this terminology. So coming back to multiple use of this terminology. So the last one, transposition, is Dr. Anderson, the Robert Anderson's preference. And I'm arguing Actually, if you say it's just a transposition, why don't you specify what are transposed? So let's say if your LV is on the right, RV is on the left, ventricles are transposed. So that's why transposition is not good enough. I'm still thinking that the best terminology for this specific entity is transposition of the great arteries. So classic morphologic features of transposition: usually aorta arises from morphologically right ventricle through muscular infundibulum. Pulmonary artery arising from usually morphologically left ventricle, usually, not always, without muscular infundibulum. And then aortic valve is usually on the right and anterior to pulmonary valve. That is the so-called classic morphologic features. And then outflow tracts are very parallel and relatively short. The outflow tracts are relatively short. So let's think about what is infundibulum in normal heart. So this is the pathologic specimen of the right and left ventricles. The membranous septum is transilluminate from the right ventricle side on the photo of left ventricle here. So here that you can see that the pulmonary valve and tricuspid valve is separate, while that aortic and mitral valve are continuity. We use quite different terms in describing this. What it is that we say right ventricle has a crista supraventricularis, while left ventricle does not. So in the European terminology, right ventricle, a semilunar valve and AV valve is separate by the presence of the ventricular infundibular fold. The left ventricle, aorta and mitral valve, in between, there is no ventricular infundibular fold. And then in right ventricle, there is discontinuity between AV, VA valves. In left ventricle, there is no AV valve, the VA continuity, there is continuity. And then all of this actually is describing infundibulum. When there is a crista, when there is a VIF, when there is discontinuity, you are gonna have infundibulum. If you don't have a crista, if you do not have a VIF, if you have a continuity, you do not have infundibulum. So what I'm emphasizing here is that we are describing almost the same thing using different words and from the different perspective. So this is the infundibulum of the case with the transposition of the great arteries, okay? So same thing, in the right ventricle, there is crista supraventricularis. By European terminology, there is a VIF separating the two, the semilunar and the AV valves, and there is discontinuity, therefore there is infundibulum. In the left ventricle, there is no infundibulum. Here, however, there is some difference between normal and transposition. So this is a normal infundibulum of the right ventricle. You can see infundibulum in the normal pathology specimen is rather long, while infundibulum in the transposition of the great arteries pretty short. That is important to recognize, because that if you do a sort of the outflow tract reconstruction, you'll be confronted with the completely different kind of the scene because of this difference. So the reason why that happened is that this is the basal view drawing seen from above. So you can see tricuspid, the aorta usually is right anterior to pulmonary trunk, while in normal, pulmonary trunk is the left side anterior. What it means is that ventricular infundibular fold, or crista supraventricularis, is quite the long structure in normal, while in the transposition, that is pretty short. Why does that happen? Because aorta and tricuspid valve are on the same side, while in normal, tricuspid valve and isthia semilunar valve is on the opposite side. So short infundibulum is actually another pathologic criteria, the characteristic of transposition of the great arteries. Okay. So think about what is having an infundibulum. So this is a cartoon showing the complete transposition or transposition of the great arteries. Okay. So if you the pulmonary trunk happen to have its infundibulum, the pulmonary trunk will gonna move forward. Okay, that's how it gets the infundibulum. What I'm explaining here, oops, I hit the end of one. Okay, wait a second. No. So somebody need to mute. Sorry about that. So moving that forward, and then what it does, the infundibulum actually displaces the arterial trunk forward and upward so that it is related and try to be connected to the anterior located ventricular chamber. So that's why double aortic right ventricle, you have a similar spectrum. You have your great arteries more commonly side by side. And the other is that at imaging and surgery, if we see the great arterial trunk very forward, just behind the anterior chest wall, they expect the infundibulum is long and then is more likely related to the anterior chamber and then usually connect to that anterior chamber. So that is a general rule I introduce. And then to go for the associated lesions, and then PFO in the newborn is in almost every, the newborn having transposition, and then actual ASD is in 10%. And then PDA is in every patient, and then you can close, but you can open it by prostaglandin. And otherwise, that VSD is the most common association, and then that occurs in 20–25%. And AVSD can occur, but rare. Left ventricular outflow tract obstruction is also common, and then it occurs more frequently in the patients having VSD. Aortic arch obstruction is in 5–10%, right aortic arch is 5%, and atrioventricular valve abnormalities such as the mitral valve straddling can happen, and juxtaposition of the atrial appendage occurs in 2.5%. Okay, let's start with the ventricular septal defect. So as in simple ventricular septal defect, VSD can be a simple hole. However, very frequently, the VSD is a sort of malalignment type. So malalignment can be due to anterior displacement of the outlet septum or posterior displacement of the outlet septum. Quite rarely, the VSD occurs because of atrioventricular septal malalignment. So anterior malalignment of the outlet septum, gives you the spectrum toward double aortic right ventricle, which is commonly called Tau-Siebenting malformation, and frequently associated with subaortic stenosis and aortic obstruction. Posterior malalignment of outlet septum, you will have your pulmonary outflow tract obstruction. When you have atrioventricular septal malalignment, that can be associated with overriding and or straddling of mitral or tricuspid valve. So this is the sort of the interesting specimen. On your left side is open right ventricle. On your left side is on your right side is open left ventricle. So there is a VSD. And then above the VSD, which I labeled as OS, outlet septum, seen from the right ventricle, that seems to be sagged backward toward the left ventricle. From the left ventricle side, you can see that outlet septum is protruding toward the U. Okay? So that is a typical posterior malalignment of outlet septum. Here, when you have posterior malalignment of the outlet septum, happening is this. So door is not the kind of it's not door. It is it's sort of a window with a hinge on the top, like an attic door. Okay, so that hinge is along the aortic valve annulus, and below that, outlet septum or infundibulum septum is a door flap. And then if you say that you push that door, the window flap, and that will move the backward, and that will encroach on left ventricular outflow tract, and then make the pulmonary valve annulus smaller. That is how posterior malalignment arterial septum makes the left ventricular outflow tract, so pulmonary outflow tract stenotic. Okay. Another is that anterior malalignment of the arterial septum. There are two mechanisms of malalignment. On your left side, I'm explaining analogy for flap door, and on the right side is a sort of en bloc displacement. What it means is that both cartoons shows their transposition, and then here, flap door mechanism means that the door is opening with the hinge anteriorly and then moving toward the right, into the right ventricle, and then push the aortic valve toward the free wall, making that valve small, and pulmonary valve moving into the right ventricle, overriding the ventricular septum. Okay? So that is how that the anterior malalignment happens, and then squashes subaortic outflow tract, and then move into the spectrum of double artery right ventricle. There is another way of doing that. What it is that everything is moving toward the right side, making again aortic valve squash it and pulmonary valve overriding, everything, en bloc displacement. So example of flap door mechanism is here. So this is the 3D printed model seen from base at the apex. So you have your right ventricle, the left upper corner, the left ventricle below. You can see both great arterial trunks arrive from the right ventricle. And then you have here infundibular septum, the dividing subaortic and subpulmonary outflow tract. And this infundibular septum merges into the ventricular septum here. So that's how flap door mechanism makes the double artery right ventricle. And then the other is that en bloc displacement. Everything shifts to the right side, and then this is the product. You can see, so this is the right ventricle, this is the left ventricle. You can see that the arterial septum, which should be here, moved into the right ventricle parallel with the rest of the ventricular septum to the aorta, a little bit squashed, pulmonary artery much bigger, overriding the defective ventricular septum. So these two are pretty much that the way how transposition of the great arteries move toward the entity, which is commonly described as Tau-C-Bing malformation. Okay, so this is the example of that. This is the case actually number 3 you will be operating on tomorrow, on the second day of the host in the next week. So you can see that the right ventricle gives rise to the aorta and pulmonary trunk. Side by side, the arterial septum divides the subaortic and subpulmonary outflow tract. So from the left ventricle, right ventricle, you can see ventricular septal crest here. Infundibular septum moved completely out. It is a freestanding structure within the right ventricle, dividing subaortic and subpulmonary outflow tract. Okay, this is the basal view, the same. Okay, so this is the case. You're going to do the procedure tomorrow. So having said that, this is the transposition of the great arteries. To this case here, there is a spectrum of overriding. So there is the VSD with a mild overriding, a little bit more higher degree of overriding, and then complete overriding makes the 200% double artery right ventricle. So this is the typical, the spectrum moving from the transposition of the great arteries, double artery right ventricle with the subpulmonary VSD, which is called a Tau-C-Bing malformation. There is another additional way of the malalignment. What it is that ventricular septum and malalignment is malaligned in relation to the atrial septum. Almost the whole ventricular septum except the arterial septum is moving. How? So moving this way, leaving the arterial septum there, and then the moving here. So this is the one case we experienced. So this is a left ventricle, this is a right ventricle. Mitral valve annulus is overriding, and you have the aortic and pulmonary outflow tract. There is some stenosis, double artery right ventricle. VSD appearing close to the pulmonary valve, but there is a mitral straddling. Okay. So this is the MR image. You can see VSD is here, aorta, the left pulmonary trunk here, so pulmonary stenosis. VSD is quite large. If you look at this, the heart in short axis, so atrial septum is here. Coming here, you have a large VSD extending inlet, and then ventricular septum is here. So going back to the original position, your lower part of atrial septum is here. VSD is there, and then actually lower part of the ventricular septum, you have malalignment in such a way. What it means is that whole ventricular septum, except the arterial septum, move toward the left ventricle, making mitral valve overriding and straddling. Okay, so this is how the spectrum of it. If you have a severe degree of the malalignment, you're going to have a double inlet right ventricle with double arterial right ventricle. If it is intermediate, you have a mitral valve overriding, straddling, and then double arterial right ventricle. This atrioventricular malalignment explains another spectrum of TGA going into double inlet right ventricle with double arterial right ventricle. So here, I'm putting all these three cases together. So one is that double arterial right ventricle with the flapped arterial septum here, double arterial right ventricle with arterial septum here. So VSD is confined to arterial part of the septum. Here, double arterial right ventricle subpulmonary, actually ventricular septum, whole thing moved to the left side. So all of this has double arterial right ventricle with subpulmonary VSD. Okay, should we call all of them tau-Sibling malformation? Actually, no. So this one, VSD is confined to arterial septum. You have two great arteries arising from right ventricle. It doesn't matter whether it's a flap door or en bloc. These are tau-Sibling malformation. However, this one, VSD, is not confined to the arterial side. It is all the way back to almost reaching the crux caudis. While that there is the URV, VSD appear to be closer to the pulmonary valve. I do not think is the tau-Sibling malformation. However, in the literature, most of the time, this malformation is described as tau-Sibling malformation with mitral straddling. Different. So, lastly, let me talk about the coronary artery origins and how we describe. So, in the description of great arteries, we all agree, we describe the position of the aorta relative to pulmonary trunk. So this is a normal relationship. So this is the inverted normal relationship. This is the relationship we usually see in transposition of the great arteries. This is the great arterial relationship we usually see in so-called congenitally corrected transposition of the great arteries, or LTGA. Okay. How do we name them? So if you want to describe these origins, very simplest way is using the term facing sinuses. Okay. So here, this is the anterior, this is posterior. So for the aortic valve, so this is right anterior, right posterior aortic sinus. This is left posterior aortic sinus. So all of this can be described using right anterior, left posterior terminology. So if here the aorta is posterior, is opposite, right anterior or left anterior facing sinuses. So that is the way how you describe it. But however, it's a little bit tricky. Why? Aorta is anterior, and then you need to use the adjective posterior here. Aorta is posterior, however, you need to use the adjective anterior. That's why we always confuse when you communicate among the images and the surgeons. So it's called the Leiden Convention. I think in 1980s, it was invented, and then Robert Anderson agrees to use this terminology. What it is that in the operating room, you as a surgeon standing in the non-facing aortic sinus, not giving rise to the coronary artery, and then look at the pulmonary trunk, and then the sinus on your surgeon's the right-hand side is called sinus 1. On your left side is sinus 2. Okay, so however, imaging world, everybody is looking at this from below, like the drawing here. So that's why that there always is it sinus 1, sinus 2 type of thing. I will give you one simple way of knowing without even thinking. So if your aorta is anterior, if aorta is posterior, like normal, right side sinus is always sinus 1, regardless of whether it's normal, abnormal, transposition, or double artery, whatever. If aorta is posterior, the sinus on the patient's right side is always sinus 1. And then if your aorta is anterior, the sinus on the patient's left side is sinus 1 all the time. So this is a completely unbreakable rule. If you have that, you don't have to even think. And then look at the aorta, whether it's anterior or posterior. If it is posterior, okay. So the patient's right side, that is sinus 1. If the aorta is anterior, the sinus on the patient's left side is sinus 1. Okay. However, this terminology has an issue when the coronary artery arises, the commissures, aortic sinus commissure is not properly aligned with the pulmonary valve. Okay. So anyway, so there are multiple coronary artery patterns. So most of the people think intramural coronary artery has some issue at the time of surgery. The other is that the single coronary artery transfer at the time of arterial switch operation may give some difficulty. So that's why that pre-operatively, we really need to identify whether this pathology happens. And then in your the simulation procedure, your case 1 is here with the coronary artery anatomy usual, which means that sinus 1 gives rise to left main, bifurcating into left anterior and circumflex, and sinus 2 gives rise to the right coronary artery. That is the coronary artery anatomy you have in your case 1 today in the evening. And then the second case is that the sinus 1 gives rise to the LAD only, and then sinus 2 gives rise to the common trunk for the right, and then circumflex coronary artery as shown here. Okay. So there are some kind of coronary artery variations, including that the commissural malalignment, sometimes that the coronary artery loops around the pulmonary arterial trunk, and then intra-arterial, more importantly, intramural cause can give you the difficulty in the arterial switch operation. High takeoff is a little risky for future development of the narrowing of the origin. And then the report says that they have found that sinus nodal artery can arise from the aortic sinus, and then that is the may bring difficult situation. So just simply that they're showing that what the commissural malalignment is. So you can see that here in the specimen seen from above, this is the right side, this is the left side, and then you can see that the aorta here and the pulmonary trunk here, and then you can see aortic sinus. Just the common sinus is facing the pulmonary sinus, right? So there is a so-called commissural malalignment from aorta side. And then what happened is that the distance between the coronary artery and the destination of transfer can be far away. Right? So this can happen in various ways. And then happening is that if this happens, you may need a kind of additional procedure taken into consideration. I don't want to go for the detail because everybody has different approach. Okay, so that's it. Thank you very much for your attention. At the end of 3 talks, we're going to have a small intermission to take your questions and we answer to you. Okay. So next is that Dr. David Barron, we're going to talk about surgical principles and modifications of the arterial switch operation. Okay, David, all yours.
June, thanks. Can you unshare your screen so I can?
Oh yes, I will.
Right, coming.
Beautiful.
Thank you. You can see my slides?
Yes.
Thank you. Welcome, everybody. So great to be talking to people all over the world. And thank you, everybody, for joining the course. And we'll look forward to actually, doing some demonstrations and, all being able to learn from each other later on today and tomorrow. So this is just a quick run through, really, the concepts of the arterial switch and the sort of modifications that you can consider. Everyone has developed their own kind of way of doing it, so there's no absolute right way. But we're very much focusing on transposition of the great arteries for this weekend and all the variants that we may see. And so we're trying to really focus on how we adopt our surgery to managing the condition in all those different varieties. So as June's already beautifully explained, it's a common condition relatively within the world of congenital heart surgery. So we're all going to see plenty of cases of transpositions during our career. It's the commonest, really, kind of truly cyanotic heart condition. So, we've talked about the coronary anatomy. So before we kind of go into the surgery itself, June's already really gone through this for you, but, I think there is endless confusion about the coronaries, and you want to kind of get a way of communicating the coronary anatomy so that you're comfortable, you understand in every case. And I think the Leiden convention has very much become the convention that most people use. And again, it's the best way to think of it is thinking of yourself as the surgeon sitting or standing in the non-coronary sinus. And sinus 1 is on your right hand and sinus 2 is on your left hand. And, people do still use the Yaku classification as well. I think, it's sort of simpler, maybe too simple, but it does, really recognize the importance of the intramural and single coronaries as well. And I think June also mentioned this. I think one of the things that often causes a lot of confusion is that the surgeon tends to imagine the coronary anatomy as you look down on it in the operating room, looking down onto the great vessels from above. So you see godlike. You see all the surgeons are godlike, and so you imagine yourself standing in the non-coronary sinus with the sinus 1 on your right hand, which is the left coronary artery, commonly in transposition. And however, if you look on the right side of this screen, the standard sort of view on echocardiogram and so forth, or CT, is that you're really looking from below. So you have to turn your head around and beware that you're really looking at the coronary arteries from below, from the patient's feet. And you have to just bear that in mind when you're kind of interpreting the data. But these are the sort of typical sort of varieties. I say here's with the Yaku classification. So type A coronary anatomy, which is the commonest variety. So that's the left coronary, the LAD and circumflex coming from sinus 1, and the right coronary coming from sinus 2. And that's probably 60 to 70% of all sort of regular transposition of the great arteries. And the only other really common ones are, again, what we're going to see later today. So type D, which is where the LAD comes off on its own from sinus 1, and where the circumflex and the right come off a sinus 2. So the circumflex goes behind the pulmonary artery. So that's by far the sort of second commonest pattern. So we're going to see both of those patterns in the models that we'll be operating on later today. And the only other sort of commonish type is type E, which is again a retropulmonary circumflex, but that's where the LAD and the right come off together from sinus 1, and the circumflex is on its own from sinus 2. So both D and E are the types where you have the retropulmonary circumflex. And then the B and C Yaku classifications recognize that there are single coronary types, of which of course there are many, very many different ones, and there are probably 2% of all transpositions have intramural coronary arteries. So really important to have a strategy for managing those. And a very brief sort of comment about the classification of transposition. Again, as you know, June's already mentioned, there are an awful lot of different terminologies that are used, and you know, transposition, detransposition, transposition of great arteries, and so forth. You know, I think transposition of the great arteries is probably the proper way to refer to the condition. And really, most of us talk about you know, simple transposition, really meaning transposition with intact ventricular septum. So when people use the term simple transposition or regular transposition, they often mean transposition with intact septum, which is, you know, the majority of the cases, probably about 60% of all the cases that we see. Whereas another quarter are transposition with a VSD, and about a fifth will be the sort of complex group, which include arch obstructions, double outlet RV type spectrum, and patients with outflow tract obstruction. But really, you know, I think we're going to focus particularly, you know, if we're talking about the technique of the switch itself, really on regular transposition, on simple transposition. You know, and to mention the names, I think, you know, that we associate with the surgery. You know, Jatin from Sao Paulo in Brazil really, you know, was the first to do the arterial switch with any success in the late 1970s, and you know, it is often still called, in many places still is called, the Jatin operation. At about the same time, Magdi Yaku really pioneered the arterial switch around the same time on the other side of the Atlantic, and was very much a pioneer of developing the arterial switch. So I've got a few really short little video clips, just perhaps to get us in the mood for thinking about the surgery and all the different steps. I think, you know, it's very much an operation which has a whole series of well-rehearsed steps, and you can sort of go through them all in your head beforehand, maybe more so than many things that we do. So here's just a sort of a view from an overhead camera of starting the operation. Immediately you can see the very anterior aorta arising from the right ventricle. But the keys, I think, at the beginning are obviously harvesting of pericardial patch, because we use that to reconstruct the defects where the coronary buttons are taken out. And, you know, really take care to confirm the anatomy. So here we are, just showing, here's the right coronary clearly coming from sinus 2, and here's the left coronary arising from sinus 1. And in terms of your strategy, I think really most people these days would use bicaval cannulation, but you can use a single venous cannula. It's still perfectly appropriate to do that if that's easier. And I say respect the duct. It's obviously all these patients pretty well have a large patent ductus, and you really have to respect the duct and make sure that you carefully ligate it and secure it right at the very outset of the surgery, because if you damage the duct or the duct is bleeding, then that becomes a real thorn in your side for the entire procedure. So the first thing you're going to do once you've arrested the heart is to transect the aorta, and we'll talk later today about, you know, trying to judge the right place to do it, and then very carefully assess your anatomy. You see the importance of little stay sutures, one in each of the above the commissures, and that really demonstrates the anatomy for you, keeps you right, keeps you watching where the commissures are and displays the anatomy nicely. And I always find it easy to take out the right coronary artery first. You can see here, really hugging against the commissure, because you really want to make your coronary button as big as possible. So you're really removing almost the entire sinus with the button itself. All the time being conscious of where the coronary artery itself is. The little fine coronary probes are quite useful just to keep yourself quite confident you understand what the course of the coronary is. And then often use cautery or diathermy just to mobilize the button free from the root. There you can see a little probe in the artery, and you can just, by probing it, you can see the course of the coronary artery on the epicardium, and you can be conscious of how much you need to mobilize it. So here then, once the coronary buttons have been taken out, so I use the right first, then the left. Then I use, people do the surgery in a different sequence. I always find it easier as the next step to then repair the defects that you've created in the aorta with your fresh autologous pericardium, and to put that all in as one piece at this stage, because it helps keep everything out of your way. But some people do this much later in the surgery after the cross clamp has been removed. I think I find it easier here to do it where you've got a really nice view and you've got the whole right outflow tract laid open. I use it as a single patch. Some people put two separate patches, one into each of the sinuses. And you may want to just resuspend the commissure in the middle there, but you can see there the completed patch. And what it means is you can then fold the patch forward, and it gives you a beautiful view of the pulmonary artery for the next steps of the surgery. So as we talk about the coronary transfer, that's a really key thing, and we'll talk today and show you different ways of doing the coronary transfer. This is my preferred technique, and I think it's probably the commonest sort of technique that's used around the world, and it's the trapdoor technique, which was first sort of described by Bill Braun and Roger Mee in Melbourne in the 1980s, and really kind of overcame a lot of the problems that people were having with coronary distortion. But the idea are these medially hinged trapdoors, so down and across towards the midline, down and across towards the midline, which allows the coronaries to be slightly angulated, so it minimizes any torsion that the coronaries are actually exposed to. And this diagram on the right shows the angulation that you achieve by using the kind of trapdoor which comes out to meet the coronary button. So it minimizes the amount of rotation that the coronary button has to go through as it's transferred from the anterior aorta to the more posterior pulmonary artery. But you can see here, it allows the coronary to sit at an angle like this, rather than the dotted line, which is the angle it would have to achieve if you didn't use a medially hinged trapdoor. So I think they've been very useful, but there are other techniques of doing it, and they're sort of closed techniques, which has different described, where you have the aorta closed when you implant the coronary button. So you can just punch out defects like this and implant the coronaries into them. But you can do it even with the aorta open with a punched out defect. The advantage, of course, being is that you keep the sinotubular junction intact, and that may be important for maintaining a more competent aortic valve and aortic valve structure in the long term. And also it allows the aorta to be nice and filled, so you get a better idea of what the coronary position is going to look like when the aorta is filled and the heart is beating at the end of the surgery. Perhaps the downsides are that you can't really see the aortic leaflets so well, so you may be at risk of damaging the leaflets. And you may, of course, have to angulate your coronary more because you don't have the benefit of the medially hinged flap to receive it. But you can take your pick. People have described excellent outcomes with both techniques, and we'll be able to show you both techniques later today. So here are just quick sort of run through. I would, again, so here you can see the pulmonary arteries now being transected. Again, you've got your stitches marking your commissures. And I would start with the left coronary. And I always try and allow the coronary just to tell you exactly where it wants to sit. And it's almost always bang in the middle of the receiving sinus. And again, you can see there's the first part, the vertical incision for the trapdoor. Here's the medially hinged component, which creates that little flap of tissue in the neo-aorta. And your coronary artery button is going to go into there. And then the right coronary button, exactly the same principle. Allow the coronary button to tell you where it wants to sit. Usually you'll find it's in the middle. You try and let the button sit relatively high just to lift the coronary up nice and straight. So it may even end up almost sitting above the true sinus of the valve, depending on the anatomy of the individual case. I try not to skeletonize the coronary too much because I don't want it flapping around in the wind. You want it to try to be held, at least to some extent, be held by the epicardial attachments. But again, a little medially hinged trapdoor incision, and then you implant the coronary into that little T-shaped incision, which kind of comes out to receive the coronary button. There you can see the button going in. I tend to start at the top and work my way all the way around. But again, if you prefer, you can start at the nadir, at the lowest point, and work up each side. So next is the Lecomte maneuver. Once you've completed the arteries, that's Yves Lecomte, who was the surgeon in Paris who really described it. And remember at the outset, in Jatine's first description, the idea of the Lecomte maneuver, obviously hadn't really been conceived. And so the original arterial switches were done still with the pulmonary arteries behind the aorta, and that can cause a lot of distortion and a lot of difficulty, particularly in sort of in the right outflow tract at the end of the surgery. And really the concept of the Lecomte in the early 1980s really made a big difference, made it much easier to do. It's a really useful part, but I think you need to do the Lecomte really aggressively. So you can see little cylastics on the left and right branch pulmonary arteries, but you really want to mobilize with cautery the pulmonary arteries right out to their branching points to give you lots of flexibility and mobility of the pulmonary arteries. And then you bring them in front of the aorta. You can see just bringing the cardioplegia suture underneath it to let it come through. Some people tend to take the cross clamp and move the cross clamp in front of the pulmonary arteries. But either way, that leaves you with the aorta now behind the pulmonary artery, allows you to reconstruct the aorta. The aorta is reconstructed and the cross clamp can come off. And again, this is a good time just to look at your anastomoses, look for any sign of bleeding, and check your coronaries look nice and straight and unobstructed. Always reassuring to see the heart looking well perfused and back into sinus rhythm straight away. You really take your time to look at things, and then you can reconstruct the pulmonary arteries with the heart beating to complete the surgery. And I've said a comment there, don't lose your concentration, because often there's a temptation to feel you've done the most difficult part of the surgery, but you can easily get yourself in trouble if you don't reconstruct the pulmonary artery without, you have to do it without any tension and all nicely in line. Kind of post-operative management, well, I think the use of sort of inodilators are pretty routine now, and Muranone has taken over from the old-fashioned kind of use of phenoxybenzamine as it was first described, a kind of fixed alpha blocker. I always use an LA line, so you've got some direct measurement at the bedside of the left ventricular preload, because the LV, particularly if the patient's a little bit older, may be a little bit non-compliant and not used to, to working at those sort of afterloads. So you have to be, it's very helpful to have the LA line, because you may, even small, volume increases on the preload may really push the LA pressure up. So it's a very helpful piece of extra monitoring. And again, Andrea's going to talk about echo in a few minutes, but really nowadays in the OR, we really take time to actually look at the coronary origins, and to actually Doppler flow the coronary blood flow in the coronaries, actually in the operating room. The quality of echo now is so superb. I think, you know, you can get so much information in the operating room. You don't want to leave the operating room if you've got any concerns about the coronary blood flow. But certainly, I say the use of vasodilators are very helpful, and you may, you know, even, you know, want to tolerate slightly lower mean pressures as long as you've got otherwise a good end organ perfusion in these patients, so you're not overstressing the left ventricle. And obviously, the older patients, I think most of us are fortunate these days that we don't see many of the older patients anymore. We tend to achieve diagnosis early. But the older ones are going to be much more sort of sensitive and non-compliant in those first few days post-op. Just a quick comment about the intramural coronaries, because they're rare, but obviously much more challenging to manage. There are different ways of managing them. Obviously, I think the first thing is hoping that you've diagnosed them preoperatively. And remember that first little video clip I showed you, just to be absolutely confident that you are clear about the coronary anatomy before you start the procedure. But usually if the coronaries are intramural, it's pretty obvious once you've opened the chest and you can see their position where they're running into the side of the aorta. But ideally, you'd have been forewarned on the preoperative echo. But all of us get surprised occasionally with finding them. For me, I find this probably the best technique, is where you leave usually the two coronaries, the intramural coronaries, are close to each other, and I leave them facing forward, take them off on a patch of tissue. You often have to take down the commissure, which is coming up between them, and then you cut out a little key, a little chunk out of the what will become the neo-aorta behind the artery, and the coronary button is sewn here, creating a nice opening immediately above it, and then a little patch is placed over of pericardium, placed over here to roof it over. I say it kind of looks like a saddlebag. So here you are looking at it from the side with the coronaries still, you're still allowing the coronaries to face forwards, so you haven't got to try and twist them around when they're very close together. But very important comment here in yellow, yeah, if the origin is elliptical or narrowed, very important to lay open the origin of the coronary artery as part of the management of the intramural coronary. This is an alternative method where you lay open the intramural course, you can see in the sort of panel B, and then split it into two separate buttons and reimplant them. But I'm always a bit anxious that this puts a lot of twist, a lot of rotational torsion on the coronary button. But outcomes for the switch these days are pretty outstanding. I think, you know, for such a sort of complex surgery, I think, you know, people are achieving remarkable outcomes around the world. And I think, you know, the fact that there are these different techniques show that, you know, we don't have to always, you know, stick to one specific technique. As long as you have a technique you're comfortable with, then that's, you know, you should stick with it. These are, just for example, yeah, the UK national results. Yeah, you can look at these online. But for the, you know, for a whole, you know, sort of unredacted, you know, national registry to achieve these sort of results are pretty outstanding. And those were some of the results that we published when we were in Birmingham, really showing that that's regular, you know, simple transposition. The yellow line is transposition VSD. So even nowadays, you know, transposition and transposition VSD have virtually, you know, got the same outcomes. So another little bit of history, you know, of the switch was, you know, there's so much focus on the outcomes of the arterial switch because, you know, it has become such a sort of benchmark of neonatal surgery. And this was a really important sort of paper back, you know, in the 90s when in Great Ormond Street in London, they were concerned about a cluster of problems with the switch, and they had the sort of the grace and the sense to say, well, let's fix this problem. Let's make it better. And Mark Laval asked Bill Braun from Birmingham to come and help him and change his techniques. And it was really, you know, it was just I think a little landmark in sort of surgical practice of to show that people were not shy to come forward and say, if I've got a problem, I'm going to go to an expert and fix it, and be open about the way that you run your surgical practice. And I think it really has changed the landscape in a way of the way that surgeons are much more transparent now about the way they manage all of their surgery and report their outcomes. So I think I'm probably going to stop there. Actually, we could talk about, because I think if we had a bit more time, we could talk maybe later today about how the technique that you use may influence the outcomes, because although we were just showing there that the outcomes for surgery are outstanding, there are still the post-operative problems that we see with the patients related, and some of it may be related to the techniques that we use. So the things that we do in the operating room are really key, not only to getting the patient home, but they may influence their longer term survival. And inevitably, because our outcomes are so good, you start to look at the longer term outcomes to try and think of the right procedures to do. But we can talk about that later on. So thank you very much. We'll move on to Andrea Dragulescu, who is our echo specialist, to talk about some of the imaging things we can learn about the heart. And I look forward to speaking to you all later. Andrea, you okay? You there?
Yes, I'm here. I'm just trying to figure out how to share my screen. Share screen.
Usually on the right upper corner. Okay.
You see my screen?
Yep.
And you can hear me, obviously. Yep. Excellent. Hello, good morning or good afternoon, or good evening, wherever you are.
Correct.
I'm very happy to be here, and I want to thank again Shi-Joon and the other organizers for inviting me to speak and including me in this wonderful course. There will be some overlap with the previous presentations. Obviously, talking about transposition, we have to talk about anatomy when talking about imaging. So we'll try to do some correlations between anatomy and echocardiography and show you some nice examples of different variants of pathology. When talking about transposition, it's a term that is used in several fields, like, for example, in genetics, where it represents a movement of a gene or a set of genes from one DNA to a site to another, or in music, where it's the act of playing or writing a piece of music in a different key from the one used originally. Also in mathematics, as a permutation of a set of elements that interchanges two elements and leaves the remaining element in the original position. So it's a state of being transposed or a transposed form of something. And we use in cardiology, in pediatric cardiology, as Shi-Joon mentioned before, when we just say transposition, it's clear for all of us that we talk about the transposition of the great arteries. Its definition is a conotruncal abnormality in which the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle, resulting in a ventricular arterial discordance. The incidence ranges from 23 to 38 per 100,000 live births, and it's fairly uncommonly associated with chromosomal abnormality. So in short, it's a discordant VA connection. So concordant AV with discordant VA, that's a simple transposition. We're not talking today about the congenital corrected transposition or a discordant AV and VA connections. You can encounter it with usual atrial arrangement or more rarely with mirror imaged arrangement. But the important thing is that you have a discordant VA connection. Anatomically speaking, we have a simple TGA about half the cases, and a more complex TGA, which has associated lesions, most commonly VSD or multiple VSDs, outflow tract obstruction, either left outflow tract obstruction to pulmonary artery or right outflow tract obstruction, often associated with arch obstruction as well, or any associated lesions that you can imagine. Now, talking about echocardiography, we start with a preoperative assessment. What we need to do is to make the diagnosis, of course. And actually, I'm on echo call this weekend, and we just had a new transposition that had a balloon septostomy about an hour ago. So it's important to make the diagnostic. There is an urgent intervention that needs to be done in a newborn baby with transposition. It's important to assess the hemodynamic mixing and then do a full segmental analysis with associated lesions, including assessing the coronary artery pattern. You've heard already quite a bit about the coronary arteries. You'll hear quite a bit more from me. We often make the diagnostic prenatally, and it is important, and this has been shown that it improves the outcomes of these babies if we can know ahead of time that there is a transposition, and we can assess the atrial septum, which will predict more or less the mixing and the hemodynamics of the newborn once it comes out. And you can see in this fetal sweep that you have the pulmonary artery coming out of the left ventricle with branch bifurcation, and then the aorta, so PA branches, and then the aorta more anterior coming out of the right ventricle. Postnatally, as I mentioned, we have to make the diagnosis, and here we have the diagnosis in this. Well, usually need one good subcostal sweep, and you have most of the anatomy figured out, and we can see a big pulmonary artery coming out of the left ventricle. I stopped it. Pulmonary artery coming out of the left ventricle, aorta coming out of the right ventricle. Characteristic is the parallel disposition of the great arteries, and also in this subcostal sweep, we can already assess the atrial septum, which has here a PFO that is, the atrial septum is bulging towards the right. The PFO is likely restrictive. We have to assess the intracardiac mixing, as I mentioned earlier. And here again, we have a atrial septum. Sometimes the septum is quite thin in the foramen ovale, and there might appear to be a hole, but it's important to assess with color and with Doppler to actually see the flow, the blood crossing the atrial septum. Here it's almost an intact aneurysmal septum with not a lot of shunting at the atrial level. It would need to open this up. We can have shunting at the ventricular level and at the level of the great arteries with a PDA. And we often keep these babies on prostin until we figure things out. So all this intracardiac mixing, well, extracardiac as well, at the level of the PDA, is important to assess the hemodynamics and see what's going on. Why is that so important? Because we have parallel circulations. We need oxygen to get into the body of the baby, and the determinants of systemic saturations are mainly related to the interatrial shunting, because it's a low pressure mixing, and it's the best place to have a good mixing. It's a rare true ASD, but more like a PFO. And you know that PFO, it's a flap that when the pressures in the left atrium rise after birth, and with the increase in pulmonary circulation, it may close. We need to assess that and assess the need for balloon atrial septostomy. If we have additional shunting, that can help for sure. Intracardiac mixing. Here we have an image. I always found this atrial septostomy quite impressive. The way we pull this balloon through from the left atrium to the right atrium, the way into the IVC to rupture the atrial septum and create a nice interatrial communication. And immediately you hear it on the monitor, and you see the saturations going up. It's quite a nice feeling. Moving on to the segmental analysis, we have to look for associated lesions. As I mentioned, the most common lesions that we look for are VSDs, outflow tract obstructions, left or right outflow tract obstructions, and then the coronary pattern. But other things can be present as well. Talking about the ventricular septal defect, almost half the cases of TGA have a VSD, most commonly a perimembranous, in perimembranous location. But other outlet VSDs can be present, muscular outlet or doubly committed, also can have muscular trabecular VSDs, or more rarely inlet VSD. Then we go through some examples. Here is one of Shi-Joon's models with perimembranous VSD that you see here behind the tricuspid valve, and also in a pathology specimen, the VSD located underneath the Pony valve here, with continuity between the tricuspid Pony valve and the VSDs in the perimembranous region. And in an echo example, you see the pulmonary artery coming out of the left ventricle, bifurcating into branch PAs. You see the tricuspid valve here, the continuity between the Pony valve, tricuspid valve, and the big perimembranous VSD. We assess the size of the VSD in multiple planes, ideally orthogonal planes, and we assess the shunt across the VSD. You can have a malalignment type of VSDs, and here we have posterior deviation of the outlet septum that encroaches on the subpulmonary outflow tract with a size discrepancy between a bigger aorta and a smaller pulmonary artery. Here is the outlet septum that is deviated posteriorly, creating subpulmonary obstruction. And I have a similar case with an echocardiogram where you see the parallel great vessels. You see the Pony artery. The Pony valve actually is pretty good size. We have a prominent outlet septum that is very deviated posteriorly, creating severe left ventricular outflow tract obstruction, severe subpulmonary obstruction. Here is an example where we have multiple muscular VSDs. It's important to assess the presence of additional VSDs, even if we identify one large outlet perimembranous VSD, to look if there are any additional VSDs that might need to be addressed during surgery. Here is a pathology specimen with a doubly committed VSD, where we have a large VSD that is in continuity with the aorta as well as with the pulmonary valve. We can see that very nicely with echo as well. You have continuity between the pulmonary valve here, slightly smaller. It was actually a bicuspid pulmonary valve, and the larger aorta with no outlet septum in between. More rarely, we can have transposition of the great arteries associated with an AVSD. As you can see here, the common AV valve and the aorta coming out of the right ventricle with pulmonary artery coming out of the left ventricle, parallel disposition of the great arteries, and the common AV valve here underneath the outflow tract. Now talking about outflow tract obstruction, while right ventricular outflow tract obstruction is a little bit more rare, associated with anterior malalignment of the outlet septum, and that obstruction is often present at multiple levels, subvalvar, valvar, and going on to arch hypoplasia and coarctation of the aorta with an interrupted aortic arch. The left ventricular outflow tract obstruction is more common, occurring in up to a quarter of TGA cases. And there are multiple mechanisms of the pulmonary, subpulmonary outflow tract obstruction, and their presence and severity can influence the surgical options. And you have here a cartoon of the different levels that we have to assess for obstruction on the left ventricular outflow tract. At pulmonary valve level, we have a posteriorly deviated outlet septum. If we have a septal bulge, we can have a fibrous shelf. We can have abnormal caudal attachment of the mitral valve, or sometimes straddling tricuspid valve that creates some obstruction, and have just tissue tags or left-sided ventricular infundibular fold that can all, there's almost never one single mechanism of obstruction, but more often multiple levels, and it's important to identify all of them. And here we have an example of a perimembranous VSD that is cradled in between the limbs of the trabecular septum marginalis with fibrous tissue there and here, along its margins extending into the subpulmonary outflow tract that you can see here, with a thickened and dysplastic pulmonary valve there with pulmonary valve stenosis. We have subvalvar and valvar obstruction, maybe a little bit of septal bulge as well. The left ventricular wall is very thick. Here's an example of the valvar obstruction. We actually don't have a subvalvar obstruction in this particular case. It's the case with double-committed VSD, so no outlet septum, no posterior deviation of the outlet septum because we don't have an outlet septum, but just a pure valvar obstruction with a somewhat hypoplastic pulmonary valve annulus. Another example with an aneurysmal tissue tag underneath the pulmonary valve that creates some obstruction. And here it's large perimembranous VSD with posterior malalignment of the outlet septum, encroaching the subpulmonary outflow tract with actually a very hypoplastic atretic pulmonary valve over there. Big aorta. In this example, we have mitral pulmonary discontinuity. You have here a left ventricular infundibular fold and a mild septal bulge that you can see here. The interventricular septum is pushed a little bit posteriorly. That creates very mild subpulmonary stenosis. This is not significant, and with surgery will not require anything done. And moving on, you've already heard about this today, the relationship of the great arteries. It's important, and normally it's called the DTGA. The aorta is anterior and slightly to the right of the pulmonary artery, like in this image here on the left. But we can have the aorta completely on top, superior to the pulmonary artery. We can have the great arteries in side-by-side position, and very rarely we can have a posterior aorta with a transposition, which is more difficult to diagnose, and it's quite rare. I've only seen 2 cases. Talking about the coronary arteries, the nomenclature, you've heard a lot about it. Again, some repetition, hopefully it will stick. For me, the way I usually explain it to the fellows, so that you don't get confused, try to just remember the usual pattern with the left coronary artery from sinus 1 and the right coronary artery from sinus 2, and then go from there with all the other variants. If you have the aorta anterior and to the right, that would be sinus 1 and sinus 2. Anterior, posterior, again, you just rotate a little bit, side by side, and you maintain the same relationship between the great arteries, and the nomenclature goes with it. Very important to assess the commissural alignment or malalignment for that matter. As you've heard from David and Shi-Joon, that it may affect the way you transfer the coronary arteries and the way you can reimplant the arteries into the neo-aorta. And here is an example of good commissural alignment. So the commissures come right one on top of the other. You can have mild commissural malalignment, or you can have significant commissural malalignment, like we have here. The aortic commissure comes in the middle of the cusp of the pulmonary valve. Because you have a bicuspid pulmonary valve, that changes even more. Now, talking about the coronary artery patterns, as you've heard, the usual coronary pattern, it's present in about 2/3 of cases. The percentages may differ from study to study, but the majority of cases anyway have this usual pattern with the left main coronary artery with LAD and circumflex from sinus 1 and the right coronary artery from sinus 2. And this is the echo images. As David mentioned, we look from below the arteries for you surgeons, and it would look more like this. The second most common pattern, have the circumflex from the right running posterior to the coronary artery, and then single coronary arteries and all the other variants. And I'll go through some examples with echo. So here we have the usual coronary pattern, have aorta, coronary artery, aorta almost superior, anterior to the coronary artery. And we have the right coronary artery from sinus 2, the left from sinus 1. It's important to see the ostia with 2D as well as with color, as otherwise it can be quite tricky. And I will show you why. Again, Bovie's usual pattern, we see flow going into the right coronary artery there. We see flow going into the left coronary artery there, and we actually get to see the bifurcation of the left coronary artery. It's not always very easy to see the bifurcation of the LAD and circumflex, though it's always good, and we always try to see that there's no coronary running behind the coronary artery, which will make the second, the other common pattern with the circumflex coming from the right. We can look at ostium from other views. It's not, we can't always see them very well from short axis, although that's the ideal picture, because we can assess the commissural alignment as well there. Here from the subcostal or apical 5-chamber view, you can see the origin of the left coronary artery, as well as the origin of the right coronary artery. In short axis, we look, we usually rotate the probe a little bit to open up the right coronary artery from sinus 2, but the left coronary artery in clear short axis usually gives us the image. Either in apical or from subcostal. If we sweep from 4-chamber up towards the outflow tracts, we would see a vessel crossing between the 4-chamber behind the coronary artery, that in 99.99 whatever % of cases would be the circumflex coming from the right. So we see a vessel running posteriorly here, like in this example, see in this still picture. This is the circumflex coming from sinus 2 together with the right coronary artery. Another example of the same coronary pattern, 1L2RCX, a big juicy left coronary artery here that doesn't seem to bifurcate. So that's the LAD. And then from sinus 2, we have a big right coronary artery, but we also see an early bifurcation with something going behind the pulmonary artery. That's the circumflex going behind. This image also shows the circumflex coming from the right, but it's in an older kid after arterial switch. Just as an example, rarely we can have a double loop, and this is more commonly seen when we have a side-by-side arrangement of the great artery, so aorta here to the right of the pulmonary artery, and we have the right coronary artery from sinus 1 looping anteriorly and going towards the right, and from sinus 2 here we have the left coronary artery going posterior to the PA and then bifurcating into LAD and circumflex. So here comes a tricky part. We have usual, so aorta anterior and slightly to the right of the coronary artery. We have this image which would show, seems to show very nicely the origin of the left coronary artery from sinus 1 bifurcating with color. We almost can convince ourselves that the left coronary artery comes from sinus 1 and bifurcates, but then if we work a bit harder the image, we can actually demonstrate that the left coronary artery comes from sinus 2 and goes interarterial with an intramural course before coming out on the other side. And this is a created image, it's a false image, have a very thin aortic wall from the intramural course that makes it look like the coronary originates normally, but it's actually not. And here is an example of the same thing. We can convince ourselves that the left coronary artery originates normally, but with better imaging and with color, we see the coronary flow in between the great arteries with a very thin wall and a very acute origin, acute angle of the origin of the coronary, making it highly suspicious of intramural course. And we have the commissure over here, so there's definitely commissural malalignment in this case, and then we have the origin of the coronary arteries with intramural, early intramural course of the left coronary artery. Here's an example of a single coronary artery. We have a big coronary artery that trifurcates quite early in this case, with the right coronary artery looping anteriorly and then the left bifurcating into LAD and circumflex. And we see that nicely with 2D as well as with color. So just to summarize, for the preoperative assessment, TGA is one form of VA connection, and it's very important to assess all associated variables, the presence of VSDs, outflow tract obstruction, coronary anatomy, arch, and everything else. You know, we have simple versus complex transpositions, and it's important to work together as a team, the imager and the surgeon, to make sure that we have the correct diagnosis and we identify all associated lesions in order to make the right plan for the surgeon to act on. I am skipping this. You've heard already a full presentation on the surgical aspects of the transpositions, and I'll just move on to talk to you a little bit of the intraoperative assessment of the transposition that we usually do with transesophageal echocardiogram. The goals of the assessment being ventricular function, looking for residual shunts, ASD, VSDs, looking at the outflow tracts if there is residual obstruction or if there is neo-aortic insufficiency or neo-PI. We're looking at the mitral and tricuspid valves for regurgitation or obstruction if in some cases. We definitely coronary ostia, the reimplanted coronaries, looking at the flow and the flow patterns and the velocity in the ostium in the coronary arteries. We're looking at the branch coronary arteries as well as the aortic arch if there was a question about the aortic arch. In some cases, and for specific indication, we use epicardial echocardiography, and the indication for that are mainly related to coronary arteries if we don't see them well by transesophageal echo, sometimes for branch coronary arteries and for the aortic arch. The epicardial echocardiogram is better for those indications. And I'll only concentrate on the coronary arteries for the assessment for time reasons. I can spend the whole day talking about echo and showing you residual lesions and complications or just the way we look at things. But here in Toronto for many years now, we look at the coronary arteries in transpositions and not only. And I think have a lot of experience with it, and we learn along the way what it means and what we can do about it if we need to do something about it. So this is one example with usual coronary pattern, transesophageal imaging. So we are looking from behind the left. That is the aorta coronary artery here. This is the right coronary artery that was reimplanted and has nice laminar flow into it. And here we have origin of the left coronary artery, and we have some flow acceleration in it. And when we Doppler the left coronary artery, we have a peak velocity around 120 centimeters per second, which in our experience is too high. We like it to be about 80 or less. So because of this flow pattern, also with occurring mainly during systole, the surgeon decided to try to adjust a little bit the left coronary artery, and after some adventitious release and trying to make the flow better in the coronary artery, we actually ended up not significant change, and the flow pattern now is more in diastole, but the velocities are still quite high, around 130. So we were not very happy with that. It was felt that maybe the left pulmonary artery was compressing a little bit the coronary artery. So went back and readjust the coronary as well as the left coronary artery. And an hour later, when we reassess, the left coronary looks a little bit on the small side here, but the flow pattern is definitely much better, with a velocity around 80 centimeters per second and a nice flow pattern, mainly diastolic perfusion. Just to confirm, we moved on to do epicardial echo to look at the coronary arteries as well as the coronaries again, and we see the left coronary artery nicely opening, bifurcating there with a normal flow pattern in it. All right, another example here directly with epicardial echo. Coronary artery in front, aorta, no aorta here. We have the origin of the left coronary artery here, nice and open ostia with laminar flow, a nice normal flow pattern, low velocity diastolic flow. But when we looked at the right coronary artery, in this case, the no pony valve is there, no aortic valve is here. That's the ostia of the right, and a little bit further down, about this would be a centimeter, so maybe half a centimeter from the actual ostia. There seems to be flow acceleration and very abnormal flow pattern in the right coronary artery. This here is the right coronary artery behind and above, and this should be the SVC, just to orient yourself. So after manipulation of the right coronary artery, here we see, again with epicardial, a very nice flow pattern that normalized and see it better with color, but also documented with a Doppler. So we were very happy with that. And just to show you an example for the branch coronary arteries, where we look at them with epicardial echo after the Leconte maneuver, right? The coronary arteries are hugging the ascending aorta, and we assess the flow in both branch PAs, and we Doppler them to assess for residual obstruction, for the presence of obstruction. I think for the interest of time, I'll stop here. I'm happy to answer any questions later on. For the post-operative assessment, depending on the anatomy pre-op and what type of surgery was done, we have different protocols, and we have to look at everything from was focusing on function, AV valves, outflow tracts, branch coronary arteries, and coronaries sometimes if we have worries or questions about them. So just to conclude, I would say that echocardiography is the main imaging modality for pre, intra, and early postoperative assessment. In all the kids and teenagers, sometimes imaging with echo can be difficult, so they may require other imaging modalities. It is very important to identify all the associated lesions to classify high risk, to identify the high risk variants, like intramural coronaries or outflow tract obstruction that require special attention. And the intra-postoperative assessment of recognition of residual lesions to see if something needs to be done then. And again, I love working with surgeons, and I think collaborating, the collaboration between imager and surgeon is very important. Thank you very much.
Okay, thank you, Andrea. That was great. So the major purpose of this talk and this surgical conference is that we usually find that cardiac surgeons need to have a good understanding on the echocardiographic views. So they try to make you as familiar as what the current status, and also that to help you building ability to ask the cardiologist how to do the images, how to interpret images, and then how to ask echocardiography what to do. Okay. So I wish that is helpful. So basically we have 3 talks to finish it. I did the morphology, Dr. Barron did the surgical techniques, and then we have the Dr. Dragulescu talking about echo assessment before and after surgery. So although that this is just right on time, but however, I want to offer that about a 10 minutes break for the questions and answers. So from the audience, anyone who has answer, just please unmute button, push the unmute button, and then identify yourself, and then ask your question, and then whom to ask. Let me ask you, David. So, how important is the commissural malalignment when you do the arterial switch operation?
Well, yeah, it's very important. I think there is you see different degrees of commissural malalignment, but when you've got kind of complete malalignment, so that the whole sinus is fully facing the pulmonary artery behind it, then you really got to make a judgment in the surgery whether you're going to need to implant the coronary buttons into the same sinus, which they generally don't tend to want to do. So it's really helpful on the pre-op echo to see the alignment of the commissures. It seems, I must say, I've sometimes found that commissures that look a little bit malaligned on the echo actually turn out not to be at surgery. I'm not quite sure why that should be, but again, it's just something you've got to be thinking about, and that that you always don't presume it's going to be normal, and so really look carefully when you transect the great vessels and make sure you've got a comfortable idea where the commissures are and how you're going to put the coronaries in, because the coronaries are going to tell you where you want to put them in. You haven't got much leeway to move them. You've got to put them where they want to be, and if that's close to the commissure, then that's where it's got to be.
Would you ask me to develop another surgical simulation model for some commissural malalignment?
I think that would be an excellent idea, June. Mm-hmm. Yeah, it'd be great. It would be very good to help you think out about it. Sometimes you can put the coronary buttons in a little bit high, so they almost sit above the commissures anyway, so you haven't got to worry too much about them. But you can't do that. You've really got to decide what you're going to do, whether you're going to put them in the same sinus or not.
Another related question is that post-operative echo and MRI, I infrequently see that coronary artery implantation is quite high above the ST junction. And then my question is that when do you need? And then the second question about that is that would it be a risk factor for long-term outcome in terms of coronary circulation?
So if you place them high above the sinus?
Mm-hmm. Yeah.
Yeah. Well, I don't think we know enough to answer that question. It doesn't seem to be. I think for sure you generally find that the reimplantation of the coronaries is slightly higher than their sort of normal appearance in a normal aorta, where they're absolutely bang in the middle of the sinus. They do tend to sit a bit high, and I think surgically we tend to do that deliberately because it just helps sit the coronary up a little bit straighter and reduce the risk of it just kinking at its edges. Yeah. So you do sit them high. I don't really see that it's ever been shown to be a specific issue in doing so. I mean, there are one or two case reports where you can see that the coronary is so high it's being squashed by the pulmonary artery of the LeCompte in front of it, but that's actually very unusual. So the simple fact of placing them high doesn't seem to be an issue. And it might be that you preserve the intercommissural distance of the valve leaflets better by placing the coronaries high. So you may get better aortic valve function by doing it, but that's kind of speculation. No one's really been able to study in detail the long-term impact of that kind of specific technical difference. Any of
the questions from the audience? Please actively engage in and then ask any questions, please. Okay, so have there been any issues that in this talk from listening from other side? Any comment?
No, I think it's so far worked really well, June. Brandon's also opened the chat, so
okay.
Whilst I do my talk, if anyone has any questions directly to any of the proctors, they can put it there too. But obviously in these sessions, we want to make them as interactive as possible. So if anyone has any questions, please turn on your video and deliver the question.
Okay.
Good. So the Nabil, you are right on time. And then as I mentioned, that Nabil Hussein is the phenomenal research fellow until June this year. So honestly that I boast that our 3D printing program is pretty much the most experienced in the world. But however, in the last 2 years, having Nabil here, really we are able to improve the quality of the 3D printing and the logistics of hosting, and then all this kind of assessment tool. And then he made tremendous contribution. And specifically, I asked him to do a talk on this because that we have a pretty robust assessment tool for the arterial switch operation. Okay, Nabil, go ahead.
Thank you very much, and it's great to see some familiar faces. Actually, thank you for that introduction, but I think you've made the biggest leap since I've come back to England in the program. But anyway, we'll carry on. So I've been asked today to do a presentation on objective assessments of host. And the main program is split into 3 main departments. So clinical uses of 3D printing, you probably see this on the news, in lots of literature, and there's lots of case reports of how clinical models have been useful in surgical decision making. There's a lot of that's been done on education, and in research you can use 3D printing. But in the purpose of this talk, primarily be talking about the educational aspect. So quick overview of 3D printing. It is quite a laborious and arduous procedure. You start off getting the cross-sectional image data, and you do all the designing and the segmentation, and then you go on and do the 3D printing once you've made the STL. It doesn't stop there. You have to do a lot of post-processing, cleaning the models, dyeing them to get them to a stage where they're ready for anatomical demonstration, or in our case, what we're going to do this weekend is surgical simulation. So let's talk about the host and the educational aspect of that. Me, myself, I'm a cardiothoracic trainee in England. And actually, it's funny that June mentioned that the silicone experts contacted him after watching the YouTube video. I did the exact same thing about 3 years ago. But as a surgical trainee, as a lot of people who are attending this course are, we're anticipating this. There's a decrease in training time, and there's an increase in patient expectations. And being congenital heart surgery, being a very technically challenging specialty, this could happen in terms of having longer training, further specialist training required for junior staff or consultants, potentially a significant workforce problem when senior surgeons decide to retire. And overall, it can make it a less attractive specialty, but all the people in this talk probably think it's the best specialty. And this has been identified as a bit of a problem in terms of trying to train the next generations of surgeons to be competent in congenital heart surgery. And these are some of the lines that they've mentioned, some of the quotations. There's an increased expectation of more junior level surgeons to continue to rise. There's an improvement required in the training and teaching methods. We're lacking in creating a more functionally successful environment to allow the clinical maturation of our junior partners. So how do we solve this problem? Well, we can look at other fields of life and people at the top of their game, and how do they get to this level? Simple. Behind the scenes, they continuously practice, and we try to use these methods in surgery. And it's successfully been done in other specialties within surgery and across medicine. And before we embarked on this, looking at objective assessments, we did a quick literature search to have a look at what simulation exists in congenital heart surgery, and in fact there was very little. So we made this hypothesis: with deliberate practice, surgeons will not only be quicker but also perform better. But how do we actually measure this? So we developed this tool. We call it the host congenital heart surgery assessment tool, and we initially started it for the arterial switch operation. So there's lots of assessment tools out there. We probably all have the 1 to 5 OSAT scale, but what we decided was to try and merge 2 types of assessment tools together. So a binary assessment tool is just a checklist. Do you perform the task correctly, yes or no? It's a very objective method. It limits any bias, and potentially, if trained, can be performed by anyone. But it's very rigid. You make a binary assessment tool for a specific procedure, and you're unable to discriminate between the importance of steps. Whereas a 1 to 5 scale is commonly used. You can use it for multiple procedures, and you can discriminate the importance of steps. However, it is open to bias. For example, if you do something perfectly, one proctor might think it's a 5 out of 5, one might think it's a 4 out of 5. There is a little bit of subjectivity there, and that increases the threats to validity. So what we thought is we'll bring these two benefits together and create our own assessment tool. And this is how it looks like for the arterial switch. And you all have access to this via the website, which I'll explain later. And as you can see on the left, the arterial switch is broken down into, well, they're not simple, but simple steps. And you can either score yes or no. And each step is weighted based on the importance of the step. So for example, the anastomosis of the coronary button, that will has a high level importance. So you gain the most amount of points if you do that correctly, but if you do that incorrectly, for example, if it's kinked, you lose a lot of points. And we also categorized each step into 3 categories: fluency of procedure, knowledge of procedure, and respect of procedure. So you can imagine if you do this procedure and it's subsequently marked, you get lots of information back, and this trainee can identify where they need to improve. So once we developed this assessment tool, what we wanted to see is it consistent? So does it show more consistency with other assessment tools that exist and across different types of evaluator? That there's no statistically significant difference in score between different grades of markers, because there's a massive emphasis on getting grading to be done by your bosses. So not only do they have to train you, they have to give you feedback, but can we take some of this responsibility away to try and encourage this self-directed learning? And also discriminatory power. So can the assessment tool discriminate between a surgeon that's expected to do well or against someone who's not expected to do so well at their first attempt, like a junior resident? So the way we did this study is we got 4 non-MDs and 5 cardiac surgeons to score 10 videos of the arterial switch operation that were done at one of our courses. So 5 of these videos were done by expert surgeons, so surgeons that were expected to do very well, and 5 were done by junior surgeons expected not to do so well. These were all randomized, and they were retrospectively assessed by these non-MDs and these experienced surgeons. And what we saw was there was a high inter and intra reliability using this assessment tool. So inter-relator reliability looks at how one assessor scores compared to another assessor. And intra-rater reliability is if I scored a video today and I did it again in 3 to 6 months' time, how similar will my scoring be? And a threshold of 0.7 is considered good, so above that is very good. And as you can see here, I achieved that. And if you look at the consistency across all the evaluators, regardless of how experienced they are, from non-MD, resident rater, or staff rater, all the total scores were consistent. And they were also able to discriminate between the expert and junior surgeons, regardless of whether the overall rater was a non-doctor or a staff cardiothoracic surgeon. So what we showed was the assessment tool is consistent. There is no statistically significant difference between different grades of markers, and you can discriminate between surgeons that are expected to do well and surgeons that aren't expected to do well. So does it actually work? So we developed this assessment tool and we applied it to the arterial switch operation. So we've got 30 cardiac surgeons who have attended the course like you have in the past, and they did their first arterial switch. They were given verbal feedback from the proctors, and they were asked to do it again. And we assessed them by video recording them on the host assessment tool and on how they did in terms of time. And this is what we saw. 80% of surgeons improved in their total score between the first and second attempt, and 100% of them improved in terms of time between the first and second attempt. So to make sure this wasn't just a one-off for the arterial switch, we tried to do it for another complex operation. So we did it for the Norwood operation. And with this, the Norwood operation, like many congenital cardiac surgery techniques, there's more than one technique to do things. So we tried to have a look, can we make this assessment tool for 2 different teaching techniques? So in the Norwood, the interdigitator technique or the augmentation reimplantation technique. So this is how the assessment tool looked. In the Norwood, there's questions which are common for both techniques, but there's some that's technique specific. And again, we have the weighting and the holistic scores. So same type of study, 5 non-MDs, 5 cardiac surgeons who were the evaluators, looked at 10 videos of the Norwood of 5 experts and 5 junior surgeons. And quickly going through here, the inter-rater reliability was good. This demonstrates each question and the variability amongst each evaluator, and over 90% are above that 0.7 threshold. And this diagram, just like the arterial switch, shows there's no statistically significant difference between the different raters. So here you've got these are the expert videos, you've got the MD raters here, you've got the non-MD raters here, and they're scoring the same of these surgeons. And again, for the junior surgeons as well. And the assessment tool can discriminate between them. So again, do surgeons improve after rehearsal? Similar to the arterial switch, 87% of surgeons improved between the first and second attempt, and again, in time, they improved. What I also wanted to see was, are the results similar when the trainer isn't present? So what we need to do with simulation is to do regular practice, and it's unrealistic to expect your senior to be there continuously. So can we still improve when our bosses aren't around? And the answer is yes. So on this table, with the proctor being present for the Norwood operation, there was 24 surgeons, and as you can see, 83% of them here improved between attempts 1 and 2 in their score, and 92% of them improved in terms of time. But we did a smaller study looking at 6 surgeons who had no proctor influence. So they were given the assessment tool before, they were given training videos, and they were asked to do their first attempt. After the first attempt, they were given feedback in terms of the score, and then they did it again. And as you can see, that once with that objective feedback, they all improved in score. They didn't all improve in time, but if you see, it's non-significant, that difference. So the host assessment tool is validated for more than one congenital heart operation. It's validated to assess the different techniques used to perform the same operation, and surgeons can still improve to a degree without proctor omnipresence. But the next step was, can this platform be used to develop a curriculum? So this is what we've done at SickKids for over a year. Over the course of a year, we had 12 different sessions, different congenital heart surgery simulations for the fellows at SickKids, 7 trainees, 2 attempts each. 7 of them were assessed, and we wanted to see if this happens across the whole spectrum of congenital heart, are part of the host curriculum. And again, similar, these are all graphs look the same, but it shows the same thing. 83% of surgeons improve in terms of their score. And if we break them down to the individual procedures, again, the majority of them are improving with statistically significant improvements, and for 3 operations, near significant. But remember, there's only 7 surgeons doing 2 procedures, so it's hard to get the numbers to really have significant p-values. If you look at time, same. Improvement in time overall, and looking at the individual procedures, significant difference in terms of being quicker across the spectrum. Are surgeons able to retain the technical skills after delay? So this is another study we did looking at trainees who attended the session. After a delay, we invited them again to perform the same procedure to see if they can retain their skills. And this diagram on the left shows in terms of score, and on the right in terms of time. You can see between attempts number 2 and 3 where there was this delay, for some trainees there was a little bit dip of performance, but then it improved, and you can see in terms of time it was the same. So how does this all translate to reality? So it's hard to get objective evidence to demonstrate this, but here on the left is one of our previous senior fellows doing rehearsing arterial switch operation with the proctor surgeon as their assistant. And on the right is the following day when they're doing it in the operation. And as you can see, there is familiarity in terms of the needle positioning, how you put it through the tissue. And it's very good for both the trainee and the trainer to really rehearse and debug steps before they actually do it in reality. And these were the outcomes. And this was a senior fellow doing his first arterial switch with outcomes comparable to what you would expect of a junior consultant. So we were able to demonstrate that host could be incorporated into the training curriculum using objective assessment methods. Surgeons could potentially retain their technical skills following a delay, and hosts can be used to prepare surgeons for real life cases. This is a disclaimer. I'm not here to say this is to replace current training. It's there to be used as an adjunct to training. And we should be using this across the world. So I don't know if anyone's had an opportunity to go to this website. All the material is there. So if you go to www.3dprintheart.ca and you go to the Education Center, you have these host training videos where you can access, and on this web page, it'll forward you to a YouTube link where there's a short video and a full video of 16 different congenital heart operations and this accompanying assessment tool. So on this slide, you can see we've got them for the closed technique and the open technique for the arterial switch. So during the break, after we come back later on tonight, it might be worth having a look. And this is the example of what we have currently available. So 16 videos, all with assessment tools, and the ones highlighted in red are the procedures that we're going to rehearse. We were discussing before COVID about trying to increase how many trainees can actually benefit from our course, because it can be expensive to travel all the way to Toronto to stay there for 3 or 4 days to participate in the course. So we were thinking about this, but really with COVID and the pandemic, we really accelerated these plans. And this was our inaugural virtual host session where our trainees actually were all at home and they were performing their, this is a supravalvular aortic stenosis repair. And as you can see on the right, proctors watching and giving feedback. And that's how we've been doing the host sessions during the pandemic. So for this course, there's 2 models. These are the newer silicone models, where you have transposition with normal coronary pattern and transposition with the circumflex coming off the right coronary, and our classic Tausig-Bing model. And it will really be nice to get your feedback on how we can improve our models, because without your feedback of attending our courses, we wouldn't have been able to do what we've been able to achieve. So the structure of this course will have the attendees will be split into focus classrooms with 1 proctor per classroom and about 5 to 6 surgeons there, so the proctor can give specific advice. Obviously, it's not the same as in real life. Bear with us, but we feel this, in the current circumstances, is an excellent way to continue training for everyone. So you have the options. We'll have access to Zoom. We'll be streaming our models, and you'll be getting that verbal feedback from the proctor. However, there is also an option to record your procedures. If the quality is good, then you can send them to Mr. Brandon Peel, and then we can do an objective assessment and send some feedback to you. That's completely up to yourselves, whether you want to take up that option. And it's important that doing more continuing training beyond this host program, being in your own centers, continually operating on the models. And actually over the last 10 years, we have over 50 host surgical models that are available. And you can see on the right the different series. For this course, we've got different variations of transposition, but we have a lot more. And what's next? What we'd like to do is to try and disseminate this course globally, of which this is an example of that, to create more evidence to demonstrate its translatability to reality, but that is a little bit more difficult. There are talks to try and implement this type of assessment into certification processes and continue with this virtual format for host. And this gentleman in the top right-hand corner is Brandon Peel. He's the man behind the scenes who's going to try his best to make sure this session moves very smoothly. Thank you, Brandon. And if you have any questions, please go directly to him. And there's some publications there off the work if you want more information. And this is a photo of us all last year. And one of the important things that we've missed out on this year with all these conferences going virtual is this, the interaction, the relationships that we make by looking at this, who the attendees. Is a lot of familiar names and faces, but it's important to also try and do that the best we can on these formats. And that's the end of the presentation. Thank you very much.
Fantastic. So it's an excellent summary of the all about the host in our institution. So this is a special emphasis is that as the Nabil mentioned, that the assessment tool is objectively proved valuable and applicable, and I wish that you use that this assessment tool for your self-assessment. The assessment tool itself is in our website in each the procedure, so you can easily download and then you can do it. Okay, so Nabil, continue to introduce yourself a little bit more, and then encourage the people introduce themselves.
Yeah, as I was alluding to at the end of my presentation, it's important for the networking aspect because congenital heart surgery is a very small world, so it's important to get to know each other. Myself, I'm a pretty junior cardiothoracic trainee in the UK, but took 2 years out to do